So I've made my best to try and include the message I've been asked to deliver, which is left main angioplasty in ACS optimizing outcomes. So there are two aspects actually for optimizing outcomes. One is a technical aspect, which includes intravascular imaging, then antiplatelet therapy. So I'll focus mainly on the technical aspect because we know antiplatelet therapy in ACS patients, especially left main, we all go for stronger P2Y12 inhibitors such as ticagrelor or prasugrel. We rarely use clopidogrel in these kind of patients. So the first question is whether provisional or two stent, and this was the 2018 guidelines from ESC, which says that in true bifurcation, left main, maybe we should use a DK crush over a provisional T stenting. But I think this will change because obviously we had the EBC left main trial published only recently, which essentially showed that in distal left main bifurcation, provisional stenting is as good as a two stent strategy. So the message is keep it simple, provisional, even in distal left main. But if you need to go for two stent, I think the current recommendation is that its DK crush is better than Coulot or any other stenting. And this has been published by the DK crush group in DK crush 3, suggesting that DK crush is better than Coulot. But I would say whatever technique you're comfortable with, just do it. So whether it's TAB, Coulot, DK crush. So my preferred strategy is DK crush or TAB. Intravascular imaging should strongly be considered when treating patients with a left main stem angioplasty, whether it's elective or ACS, and there's a class 2 indication from ESC guidelines. So I would like to show some cases. So this gentleman with almost like an ACS presentation because he's been having crescendo angina, he's 87. He had a good LV function. He was symptomatic despite 2 anti-anginal therapy, but he was admitted with chest pains at rest. So as you can see, he's got a significant distal left main involving the circumflex and the LAD. And the right coronary was relatively okay. So given his age, he was not a surgical candidate. We offered angioplasty. So it was not easy to wire this LAD. We needed some slippery wire. After that, we decided to rotablate this because the balloons were not going. So we did a 1.5 millimeter burr. After that, we stented the circumflex and performed an intravascular ultrasound of the LAD and the left main. You could see it's around 2.75 distally and around 3.25 in the mid segment. And as you come more proximal, the LAD was 4.5 and left main was almost 6. So obviously we treated with true drug ring stents in the LAD. And as we came, we used 4.5 millimeter drug ring stent from left main to LAD, which was further optimized with a 5.5 millimeter NC balloon. And this was the IVUS post-procedure. You could see the stent is well opposed. And I've not shown the MSA, but you'll see in the next slide, it was well over 6 millimeters square. Obviously, this is the post-procedure. We found that there was a pinching of the ostium of the circumflex. Now, I rarely stent the circ ostium these days because the restenosis is very high in those places. So I tend to use more drug-coated balloon. So after doing DCB, we used a kissing balloon and again repot, and that's what the final result. I accepted this 87-year-old man. The last thing I want to do is put a lot of metal in his left main. This is the final result. So second case is interesting, 54-year-old man with anterior STEMI, risk factor smoking and family history of coronary disease. So his angiogram basically showed a flush occlusion of the LAD. You could see some dye hang up there. So we tried to wire this. Despite taking any slippery wire, it wouldn't catch. It kept prolapsing into the circumflex. So obviously, we tried for 5-10 minutes. Obviously, patient in cardiac arrest, having chest pain and ST elevation. So the last thing you want to do is to delay the procedure. So we used the angulated catheter, supercross. You could see the supercross is placed right at the ostium. And we were able to wire with this. And after wiring, we exchanged it to a normal wire, ballooned it, and this is interesting. So a lot of the time people want to just stent the ostium of the LAD here, but I think IVUS was the key. IVUS essentially showed, you'll see in a minute, that the plaque extend all the way to the left main stem. So this is the proximal LAD, and you'll see the wire in the circumflex coming in a minute. see the wire in the circumflex. So there was a plaque in the left main stem. So we had to put a long stent in the left main, and we kept it provisional because there was no disease in the circ ostium. And we finished with the kissing balloon dilatation, and that's the final result. So angulated catheters are useful. Ventura we don't have any more, but we have Supercross and Shift Ninja. I would like to do a third case. This was present in the Euro PCR this year, which is why I have a similar slide from last month presentation. This is a 62-year-old man, again with crescent angina in 2019, diabetic, hypertension, ex-smoker. He had a bypass in 2005 where he had lemur to LAD and vein graft to right coronary. So this was an angiogram in 2017 where he had a significant disease in the ostium of the left main. And he had a blocked right coronary and the graft to this had gone down. And the lemur was patent as always. So at this time, we treated the ostium of the left main with 4 millimeter rolling stent, which was optimized with a 5 millimeter NC balloon. So this was the post-procedure after stenting. So this was in 2017, sorry. And you could see here, this is the IVUS post-stenting. What essentially it shows is the ostium is well covered. Okay, so that's the covering of the ostium. What is the next option? Whether to do the right coronary angioplasty, which is CTO. But he remained asymptomatic until 2022, but he had recurrence of angina. So we did a stress MRI scan, which showed inferior wall ischemia. So the plan was to do RCS CTO. So we brought him for a dual access RCS CTO, but then we realized there was a compression of the stent in the left main, which was treated in 2019. So we did the IVUS, and what we found was, you could see here, the ostium is covered well, and there was no restenosis within the stent, but there was an external compression of the stent from a calcified nodule which had developed since 2019. So you could see here, there's not much disease within the stent, but what we are seeing is a compression of the stent from external calcium nodule. So obviously we did the balloon dilatation, and this is the post-balloon dilatation, which is with the 4 millimeter NC balloon. You see there's still persistent recoil. So what next? So obviously we used IVL here, and this is post-IVL. There was a persistent recoil despite using IVL. So what we do here is we decided to place another stent. So we put another 4.5 millimeter stent, and this was the final result. And you could see the final IVUS looks very nice. So nodal calcium is a difficult entity to treat, and imaging is the key. This also generates a hypothesis maybe the current generation stent lacks enough radial stent to hold the calcium nodule, because we had to use 2 layers of stent. The first was in 2019 and the one which was done recently. So my conclusion from this talk is left main stem angioplasty, provisional stenting is better, whether you're doing in the ACS setting or in the stable angina. If you want to do 2 stents, go with whatever techniques you're comfortable with. So Coulard, DK crush, or TAP. But intravascular imaging is the key for all left main cases, and you saw the cases I've shown. The imaging helped in optimization of the stents and also the diagnosis, and also the last case where the calcium nodule, we had to keep repeating the imaging to find out what was the actual cause. And even with the calcium modification with IVL, it kept recoiling and we had to use another stent. Thank you.
Thank you very much. Thank you for your brilliant presentation on left main PCI. Some multimodalities cases you showed here. Thank you.